let's jump right into this clinical simulation covering ocular and cranial emergencies. We are targeting the critical diagnostic boundaries of these infectious emergencies today because, as we know, distinguishing benign superficial infections from rapidly lethal intracranial processes is absolutely vital. Let's get started. We'll start by establishing the absolute anatomical dividing line that really dictates the severity of ocular infections, the orbital septum. Understanding this exact fascial boundary is completely non-negotiable. It's the physical barrier separating the superficial preseptal tissues of the eyelid from the deep, highly vulnerable, vision-threatening structures housed within the bony orbit. Now, this scan brilliantly illustrates the primary mechanism of orbital cellulitis. Just look at the complete opacification of the paranasal sinus here. Orbital cellulitis overwhelmingly arises from the direct contiguous spread of bacterial sinusitis. Pathogens, most notably Streptococcus, Staph aureus, and Haemophilus influenza, they essentially just breach the thin bone separating the ethmoid or maxillary sinuses from the orbital cavity. So the sinus itself acts as the primary nidus for this severe invasion. Once that bacterial invasion crosses the orbital septum, the presence of purulent inflammation inside that confined space of the bony orbit strictly forces some absolute diagnostic markers. You're going to see proptosis, or a literal bulging of the eye. You'll also observe severely decreased extraocular movement, agonizing ocular pain, particularly when the patient tries to move their eye, and decreased visual acuity. Make no mistake, these are the hallmark signs of a severe, vision-threatening emergency. Okay, so the singular clinical divergence between a superficial and a deep infection here is absolute. Both preseptal and orbital cellulitis present with acute fever and an erythematous eyelid, right? But orbital cellulitis explicitly restricts the extraocular muscles and threatens the optic nerve, causing diplopia and vision loss. On the flip side, preseptal infection is strictly confined anterior to the septum. It spares the extraocular muscles entirely, so you'll see normal vision and completely painless eye movement. To definitively evaluate for a subperiosteal abscess or impending intracranial involvement, a high-resolution CT scan of the orbits and sinuses is your immediate modality of choice, and this must be deployed alongside blood cultures and aggressive intravenous antibiotics. Do not wait for imaging to initiate empiric antimicrobial coverage. Also, you need to secure immediate ophthalmologic and ENT consults for potential surgical intervention. Let's apply this to an integrated assessment focusing on isolating the exact anatomical boundary breached by an infection. We have a 10-year-old patient with a recent upper respiratory infection. They present with a swollen, red right eyelid, fever, and, critically, an inability to look laterally without agonizing pain. So, what's our move? Let's break down the options. Option C is the only correct answer. Here's why. That agonizing pain on lateral gaze definitively confirms the infection has breached the orbital septum and involved the extraocular muscles. This entirely rules out option A, preseptal cellulitis, which requires normal painless eye movement. Option B, viral conjunctivitis, presents with watery discharge, not restricted gaze. Option D, acute Dacrus cystitis, while that's a localized medial canthal sac infection and it lacks proptosis. And option E, allergic conjunctivitis, is typically bilateral and itchy. Therefore, option C strictly matches our neuromuscular signature. This patient needs a CT scan and IV antibiotics right away to prevent permanent blindness. Moving on to Module 2, we'll look at the epithelial breach, specifically focusing on bacterial keratitis. The cornea is naturally avascular, so it relies heavily on an intact epithelium for defense. Prolonged contact lens wear actually serves as the primary mechanical vector in this pathology. It directly creates these tiny corneal microabrasions, which then provide a rapid, unhindered entry point for aggressive, vision-destroying pathogens. We're primarily talking about Pseudomonas aeruginosa and Serratia here. Once the pathogen breaches that epithelium, the clinical destruction profile is incredibly aggressive and rapid. The patient is going to present with an acutely painful red eye, profound photophobia, and a thick, purulent discharge. Furthermore, when you do a slit lamp examination, you'll see the classic findings: a hazy cornea with dense central ulceration and potentially a layering of white blood cells right in the anterior chamber, which we call a hypion. This is a massive red flag, signaling a severe ophthalmological emergency. It's absolutely critical to isolate the clinical variants when evaluating the red eye. Viral conjunctivitis, which is typically caused by adenovirus, manifests with a gritty sensation, copious watery discharge, and preauricular lymphadenopathy. It also often occurs in epidemics. In stark contrast, bacterial keratitis features intense pain, a thick mucopurulent discharge, visible corneal opacity, and significant visual impairment. So, the bottom line is that bacterial keratitis is a true medical emergency. The intervention absolute dictates 3 strict steps. First, immediately remove the contact lens. Second, following emergent corneal scrapings for culture, you must administer intensive, round-the-clock, topical, broad-spectrum antibiotics, like a fluoroquinolone. Third, and this is crucial, strictly avoid eye patching. Let's look at another integrated assessment. This management scenario demands the correct prioritization of acute interventions for a compromised cornea. Our patient is a 24-year-old who habitually sleeps in their daily wear contact lenses. They present with severe photophobia, an acutely painful red eye, and a visible corneal opacification. Option B is the absolute correct intervention here. Immediate topical broad-spectrum antibiotics are completely mandatory to halt the bacterial destruction. Let's look at the traps in the other options. Placing an eye patch, option A, in the setting of suspected Pseudomonas keratitis is quite literally disastrous. It creates a dark, warm, incubatory environment that rapidly accelerates corneal melting and permanent vision loss. Option C, oral acyclovir, is for herpes simplex keratitis, which presents with dendritic ulcers, not contact lens-associated opacification. Option D, topical corticosteroids, can massively exacerbate the infection and lead to perforation. And option E is really just supportive care for a benign sty. So option B is the only viable path. Now, for Module 3, vascular dissemination, focusing on cavernous sinus thrombosis. This catastrophic complication occurs when an untreated central facial infection, an orbital cellulitis, or a nasal sinusitis entirely escapes anatomical containment. Because the facial venous system is valveless, the infection undergoes a retrograde progression straight into the dural venous sinuses. This culminates in a septic thrombus within the cavernous sinus, an infection driven primarily by Staphylococcus aureus. The diagnostic signature here is distinctly defined by the unique, highly complex anatomy of the cavernous sinus. As the septic thrombus expands, the resulting compression forces acute palsies of the cranial nerves, running directly through or along the sinus wall. This prominently includes cranial nerves 3, 4, and 6, so the patient will exhibit profound visual disturbances, a unilateral or bilateral inability to abduct the eye due to that CN6 involvement, and this will be accompanied by severe headache, orbital pain, and marked edema. When it comes to diagnostic execution, while a CT scan is often utilized initially to rule out other pathologies, an MRI of the brain with MR venography remains the definitive and most accurate method for visualizing the septic thrombus within the dural venous sinuses. Concurrently, blood cultures must be drawn to isolate the causative pathogen, and intravenous antibiotics have to be initiated immediately without any delay. Because of the high mortality and rapid progression of this condition, aggressive empiric therapy is strictly required. The regimen must broadly cover MRSA with vancomycin. It needs to target gram-negative organisms with a 3rd or 4th generation cephalosporin, like ceftriaxone or cefepime, and it must include metronidazole to cover anaerobic pathogens originating from sinus or dental sources. This combination is administered intravenously for a minimum of 3 to 4 weeks. Let's run through one final high-stakes simulation requiring the identification of an unyielding cranial nerve deficit secondary to a septic thrombotic event. The patient has a history of an untreated nasal furuncle, a classic central facial infection. They present with a severe headache, high fever, orbital edema, and notably, a new-onset inability to abduct their right eye. Option B is the correct choice. The combination of a central facial infection, high fever, and a specific abducens nerve deficit strictly isolates the pathology to the cavernous sinus. Let's look at the others. Option A, mucormycosis, typically presents in diabetic or immunocompromised patients with a black necrotic eschar on the palate or nasomucosa. Option C, a brain abscess, presents with focal neurologic deficits but lacks this specific, discrete grouping of orbital edema and isolated CNV palsy following a facial infection. Option D, bacterial meningitis, presents with nuchal rigidity and altered mental status, but not localized orbital edema. And option E, temporal arteritis, well, that presents with jaw claudication in older adults, not an acute post-infectious cranial nerve palsy. Therefore, immediate broad-spectrum, multi-agent intravenous therapy for cavernous sinus thrombosis is the exact discrete management step required here. Which brings us to our definitive medical conclusion. The strict adherence to absolute intervention protocols, combined with the rapid recognition of discrete anatomical boundaries, is precisely what separates a benign clinical course from devastating morbidity or mortality. Fortunately, current aggressive broad-spectrum antimicrobials and advanced venography have significantly reduced the historical mortality of these complex anatomical infections, provided the clinician executes the correct diagnostic sequence flawlessly. This explainer has equipped you with the exact markers and intervention absolutes required to manage these severe cranial ocular emergencies effectively.